Um, Good morning, good afternoon, good evening, wherever you are in the world, and a very warm welcome to this Explain Pain in the Clinic. My name is Joanna, and I am Director of Noigroup Europe, and I am joined this afternoon by Luke Bongiorno. Hi, Luke.
Hi, Joe. Thanks for having me.
Oh, it's great to have you here. Luke is director and owner of Noigroup and one of New York City's most prominent physical therapists. It's great to have you, and thanks for agreeing to do this session. These sessions are all about giving you a taste of Explain Pain and how to practically use it in the clinic. Some of you will have already done an Explain Pain course, and for those of you that have, these sessions are designed to reinforce and extend what you have already learned. But if you're new to Explain Pain, this will give you a little taste of what we cover in the core courses. So just a couple of things to mention before we start. Luke will be talking for about 20 minutes. If you have any questions, then please feel free to ask them in the Q&A or in the chat, and we will get to as many of them as we can. And if you want to watch the recording of the session, you can access it either in the Noigroup Clinical Discussion Group, that's a Facebook group, which is absolutely superb, or you can go to the YouTube channel, and I'll drop the links for those into the chat whilst we are talking. So today we are going to be talking about the science of reconnection. So Luke, can you tell us what you mean by that and what you're going to cover today?
Well, that was I think your title, Joe. But essentially, we've had a few discussions, and being involved with Noigroup over the years, and since taking over, there's been a lot of discussion about the value of, say, hands-on care. I was trained as a physiotherapist back in graduated in 1996. So that's nearly 30 years ago now. And it was a strong skill set that we used. And over the years, there's been, varying degrees of, there's no evidence to support that manual therapy works or does what people say it does. And Explain Pain is more about getting a level of conceptual change, changing the thoughts and beliefs about pain, which it is. So just a little bit of my background. As I said, I was trained as a manual therapist, and it's always been a challenge for me, just as a clinician, and this was my skill set. I used my hands. How do I reconcile hands-on care with Explain Pain concepts? And one of the things that keeps coming up is it's almost like you're using touch to teach. Sometimes when our language doesn't work, my definition of a word might be different from the patient's. Or if I'm trying to tell them anything, I heard the term painsplaining. It doesn't necessarily demonstrate that empathy, that compassion, that ability that we have to listen to our patients, which is one of the things that Maitland drummed in. If you listen to the patient, they'll tell you what's wrong. If you really listen to them, they'll tell you how to get them better. So it's incorporating those skills. And with your hands, you're not just touching the painful point. You're actually helping them reconnect with their bodies. And I use that in conjunction with perhaps showing them a map of the body map of the brain in the somatosensory cortex. And they might say, I didn't realize I was sensitive there. It's not that we're doing just passive massage or just, let's mobilize the joint. You're a bit stiff. Okay, you're right as rain now. That's not how I would use manual therapy, but it's using it as a way to help someone reconnect to their central nervous system again in a safe way.
Wow, that's really cool. Thanks very much. So when you say, there was this comment in there, which is to touch to teach. How does that work for you then, maybe even with a few examples of where you found that to be particularly effective?
Yeah, well, I mean, I think, for example, someone might have a sensation. So I can give someone an explanation. We've used a lot in Explain Pain, the role of the brain in pain, or, the brain decides when it doesn't feel safe, or there's credible evidence of danger, which then sends messages out to form pain. And we know there's evidence to support that pain is an experience, output from the brain, and it can be learned over time. Oftentimes, patients find that concept just quite abstract and challenging.
Mhm.
So even teaching sometimes anatomy, or, in traditional explained pain, teaching where the nerves are and touching a point, for example, in the forearm where the median nerve might pass through the pronator teres,
Mm.
and touching one side, say their painful side, compared with the other side. And I said, oh, it's much more sensitive up there. So, well, that might be a sign that that right side is a little more sensitized. And that patient might be presenting with, say, carpal tunnel syndrome
Yeah.
or another. So you're sort of helping them become aware of what they're feeling. And then you can couple that with a visual of showing them where that nerve is. And then your movement might be a median nerve glide, opening up that
Yeah.
part. And they can tie that into, oh, okay, yeah, it does hurt when I turn the tap. And these aren't new concepts, but these are just demonstrating how that might be using manual therapy. And then I get the patient to touch.
Yeah. Oh, I love that. Yeah, I really love it. It's quite a different sort of angle on where we often come at this in these sessions. That you're coming at it really from the hands-on. I love the fact that you're adding another layer to the hands-on by bringing in
Yeah,
that idea of explain pain and actually helping the person to understand the pain, but through the hands-on, through the touch.
through the touch. And then the other thing is then, because sometimes, I'll get people will be like, or even patients, they get angry. Oh, well, it feels good when you touch it, but then what do I do now? Or, it's temporary. And I'll remind them of that. Well, but if you can
Mm,
have periods where, so how do I treat that? So say they are sensitive to touch, and the idea or the concept is that their nervous system is sensitized or
mm,
upregulated. I might then do some breath work with them and say, and that might be an abstract concept at the beginning, like just, do some slow breathing to try and reduce your sympathetic nervous system activity. So let's try and
mm,
down regulate your system or calm your nervous system. And I might get a little watch out and do just slow breathing just to distract them a little bit as they feel the tissue. And they'll notice in real time the sensitivity, or they may notice the sensitivity of that tissue
mm.
reducing. So then
Yeah,
they have a strategy to do, like, oh, wow, it actually doesn't hurt as much now. And so, well, that
yeah,
doesn't mean the tissue has changed, but now you've got a strategy. So now we're dealing with, and you're helping them differentiate between structurally what's the issue in the tissue, which
mm,
will be a point of focus, and how are you as an overall being responding to that. And that's what sometimes we can have more control over. And I use the word control. You have control over this, and it's okay that it's temporary, because pain is learned. We need to practice.
mm,
I often give them, especially when it comes to breathing and breath work, the Latin word for breath is spirit. And I think, they've done yoga, or they might do a spiritual practice. And I'll be
mm.
like, well, this is what it means. You need to practice this on a daily basis, knowing that it's just perhaps temporary, but your nervous system will learn that it's okay to be in a more relaxed state. It doesn't need to, the cells in your tissues, or whatever metaphor you might want to use, I say your little soldiers, don't feel like they need to go into battle every day or every
Mm.
moment of every day. So you can tie that then in with whatever metaphor you're comfortable with as a clinician. And you're still, it's still tied into the research that, being fortunate to be around with, Professor Mosley and countless people around the world.
Oh, great. Thank you. We've got a question from Stephen Hull, which ties in exactly to this point. How do you apply touch to teach in chronic pain patients with substantial central and peripheral sensitization, nociplastic pain?
I generally start, well, first of all, the other thing that I haven't mentioned, I mean, this is such a broad topic, it's hard to get everything in 20 minutes, but I want to try and cover as much as I can, and I'm always available for questions because it's dear to my heart, this topic. But for someone who has, I guess the question is someone has a lot of peripheral sensitization, maybe doesn't want to be touched or is quite nervous about being touched. First of all, I don't know what their history is. They might have trauma with touch, they might have been hurt or abuse, and many things. I'll ask them, are they comfortable first, which is what is standard of practice. But also I'll start generally away from that side of pain. And if they've already verbalized to me, I don't want anyone to touch it, I said, I'm not going to touch that. You might trust me, but your tissues don't know me yet. So I respect that, and I'll lead with that. Is it okay if I touch, now that we understand that pain is involving the whole being, is it okay if I touch another area, maybe your foot or something away from that side of pain, just to get a sense of how your body might react to touch elsewhere? And they might say, yeah, that's fine. So I'll start away from the side of pain. The part about the touch to teach is you're not reinforcing necessarily that, you need to push on the painful spot, which is what they might be used to or what they may have had in the past. And they may have seen a therapist 10 years earlier that pushed on a spot and they've had pain ever since. So the link is, or the association is, that made me worse or that flared me up. So, and I've been guilty of it myself in time. So that's how I might broach that topic, and then do the breath work and say, right, does the sensitivity go, reduce in that area? Or how do you feel? Oh, the muscles feel more relaxed. So I'm still using that idea of let's get you to feel in a safe environment rather than just numbing everything. So and that also might tie in with graded exposure.
Okay. Thank you.
But
We've
okay,
got some more questions, Luke. So it's going to be one of those sessions, I think.
that's good. I
So
like questions because otherwise I could just talk for hours and
we'll take these questions and then we'll sort of come back into the thread. So Stephen just goes on to say that I'm thinking of patients with substantial allodynia. Oh, sorry, I can't pronounce that word. Allodynia.
Allodynia, yeah, allodynia is
or hyperalgesia, secondary to both peripheral and central sensitization.
Yeah.
So there's a second part to that question.
Right. So hyperalgesia and allodynia is when you experience pain that wouldn't normally be painful. So an example of that is, if you had a warm shower and then suddenly you were sunburned, meaning you had a level of inflammation, suddenly that same temperature, because nociceptors are responsive to temperature, that would be painful. It wouldn't normally be painful, but it is painful. So a lot of patients in chronic pain have allodynia or hyperalgesia, having more pain than what they would. So I would, again, start with an area that's very safe, that's their least sensitive part of their body. And then I would do slow breath work with them and say, as we're doing this, can you feel anything else? So I don't pay attention to necessarily where I'm touching. I might say, as you breathe in, try and feel, are you feeling rib expansion on the right or the left? I redirect their attention of focus to an area where they can feel something that they may not normally pay conscious attention to. And I'll emphasize that my first job was actually in chest physiotherapy back in Geelong Hospital in Melbourne. So I did a lot of breathing work, and that's how I sort of help them to become, move them away from that sensitive area. And I might still have my hands on, and they'll say, are you okay with my touch? And they'll be like, oh, are you still touching as hard? I said, yes. Oh, I don't feel it anymore. I said, well, that's good news. I said, we don't need to do any more than that. Because sometimes the tendency will be to keep going and going and going. But just to have them reframe and give them that somatic experience of, okay, I have an ability to downregulate my central nervous system and perhaps help it to desensitize. That's how I handle that. And it was the same with someone with CRPS. I'm not touching their foot. And you can, it's not just touch. I'll use mirrors. I use all the other things as well. But just for the focus of this is how we can incorporate hands. Or a tactile cue is still touch as well.
What do you mean by a tactile cue? Tactile
cue might be if we're getting them to do a movement, and I would say, right, pull your shoulder back, or something that they don't feel like they have control over because they're hypersensitized. I might just say, can I just put my hand on your chest, or breathe into your chest if they can't get their shoulder back. Their chest might go forward, while the net result of that is their shoulder goes back.
Okay.
So if you can't move your shoulder, move your body on your shoulder. Don't move your shoulder on your body. It's just reframing the way they're thinking about movement, and perhaps using a tactile cue. So that's just touching them in a very non-threatening way.
Thank you. That's great. And we've got more questions. So I think, are you okay to just follow the thread of questions?
Yeah, of course. I've said enough.
We'll come back onto the. Okay, so from Pramiti, do you differentiate between chronic pain and somatic pain? Is there anything we can do to help patients with somatic pain?
If I understand the question, so I mean, when I think of somatic pain, that's pain. I think of pain experienced in the body. Chronic pain or persistent pain is just it can encompass a physical sensation. So somatic is the physical sensation. There's also, with chronic pain, I think of it as fears and thoughts and beliefs around that pain. So that's encompassing emotions as well. So I think of somatic pain, I would define as just the physical sensation associated with the pain. So I might help the patient understand that. So what are you feeling physically? Where is the sensation in your body? And what does that mean for you? So with someone with persistent pain, I'll be like, well, what's that mean for you? Do you feel like it's dangerous? Is it, I understand, really annoying. Is it dangerous? Is there an issue in the tissue? Is there damage? Does it mean damage for you? So somatic pain, I'll focus on the physical sensation. Persistent pain, I'll delve into, well, what's that mean for you? And I typically do that anyway, whether it's acute or chronic pain.
Thank you. And thank you, Pramiti, for the question. That was a great question. And this was something, I've got another question here from Karen, and this was something actually I was thinking about too, Karen. Often persistent pain patients have therapist fatigue and are disengaged with what is your number one hack for patient buy-in?
That's a great question. Therapist fatigue is also, I sometimes say to them, look, you have every right not to have any faith in me. And I'm sorry, I heard this from Peter O'Sullivan once. I'm sorry on behalf of the medical community, all the things that you've been told. And I said, I'll sometimes say, what do you think I can possibly do that someone else hasn't done? I said, I don't want you to take my word for it. I want you to trust your tissues, your immune system. And that's where I might bring in pain as a defensive, not an offensive. There are immune cells that are there to protect you, and they trust you, and they shouldn't trust me yet. But I'll say, I'm your body's defense lawyer. I mean, always add a little bit of humor. I'm your body's, I want to try and convince your central nervous system that your shoulder might be safe to move, or your back is safe to move. And I'm a pretty good lawyer, but I don't want you to, I like a challenge too. So don't believe me. Don't take my word for it. And they'll be like, they'll nod. Are you okay with that? Yeah. Do you understand that? Yeah. Is there a yes or a yes, no, or a yes, maybe, or a yeah, I'll buy in for now? I'll just add follow-up questions, and that's an approach I take there.
I love that. Thank you, Karen. And Karen said, thank you. She can feel your energy and passion. That's good. Luke loves that. He's really energized, aren't you? Really energetic.
Well, that helps me with therapist fatigue myself. I mean,
yeah,
you gotta realize, and I admire clinicians for having the courage to delve into this pain science. It can be so much easier to fall back on the techniques and the things that we've always said and done, when the going gets tough, and it takes a lot and a lot of energy. So you know, but at the same time, the reward can be remarkable when you can just help someone just through listening, just through being with them. So
yeah, I love that. I love that about you. It brings us back into one of the threads that we talked about, that you introduced, which was this idea of that the confidence with which you deliver this touch is really key to the experience for the patient. Could you talk a little bit more about that?
yeah, no, I think that ties back into, you know, one thing I'd love to see more of is just teaching coming back into schools, the sensitivity to touch. And it's not about just using your hands. You know, when I used to teach manual therapy courses, I would say rule number one is relax your hands, you know, use your direction of, you know, your body mechanics. And that's what we were taught in school. But I think just practicing it and being okay with that touch is really key. And that confidence is knowing that your absolute intention is to help to send a message to that person that's not just going to be there for that moment, but that they can take home that with and help to experience that feeling even when they're not with you. So that's what I would say is how you can deliver it confidently. And I've taught, you know, many students and therapists over time that are like, oh, but what if I don't do it properly? You know, that's that we all have doubt. Even, you know, I've been doing it for 25 years and I still, oh, am I doing the right thing here? But confidence isn't whether I'm doing it better or worse than anyone else or whether I'm being judged. Confidence is that ability to know that you don't actually need to worry about that. It's all right. I genuinely want, I know enough about my anatomy and I'm confident that I know a little bit more here than the person on the table. And I'm delivering it in a slightly different way that might have an impact on their central nervous system. And don't attach to the outcome of it, just practice it.
Yeah, brilliant. Thank you. And actually, this brings us into another question here. Stephen, I have seen your question and we're going to come back to that. Tom's question is, which pain education metaphor do you find works best?
Oh, that's a big question.
It's a big question. You're kind of on the spot now.
No, because look, it works different. I mean, I've said I used to love the Twin Peaks model. You know that metaphor of the, you know, before pain and tissue tolerance. For those that don't know, before pain, your tissue tolerance and injury line are close, and then after pain, the tissue tolerance is a little bit lower. So there's a bit of background noise. So one thing, but then I showed a patient that, and he said, "Luke, why are you showing me two mountains?" You know, the metaphor didn't make sense to him.
Yeah.
So I think it's just hard to say what's the best. It's really sizing up the person in front of you and finding something that's meaningful for them. So a musician, I'll say, look, the body's like an orchestra. You know, I see a lot of musicians or performing artists. I'll tend to go into athletes. I'll be like, well, your body's a team. And that the knee is the striker on the team. Okay. I know he thinks he's the only one and the most special one. And right now your brain is paying attention to that. So, but remember, there's, you know, the midfielders and the centers and the defensive line, all these other guys that just need, or girls that need a little bit of paying attention to as well. And the team can do a little bit better. So it's generally, those are the metaphors, the idea that we tend to focus on that one part or the bad relationship, but let's focus on the overall team and the interacting of how they work in together.
Great, thank you. It's always one of those questions, isn't it? Is that it depends question.
There's no one way, but I do like the question, but there are so many metaphors, and it's even the protector meter as a metaphor. Like everything we use is really, you know, and I think sometimes it's just good to explain to the patients. I learned this from Tim Cox too, is like always remind them that this is a metaphor, because sometimes the patient might think that, you know, there's actually something They said, oh, my brain is smudged. They think it's
Yeah.
a physical thing. Well, this is a metaphor, meaning it's a signaling issue. I love my latest one that I love is the Wi-Fi signal. I said, your Wi-Fi signal's, not on, you're on 1 bar here. Let's get it up to 3 bars. I said, you got good Wi-Fi here, but you're not going into any other rooms in the house because you want that Wi-Fi. And people
I
can
love
just
that.
relate to that.
I love that. We should maybe do a session on metaphor, Luke, next time you're on. That could be quite a
Yeah, I
fun
should
one
get
to do.
Dave Butler for a comeback.
Yeah, oh, he loves a metaphor, doesn't he?
Mhm.
Loves a metaphor. Okay, right. We're gonna take these next 2 questions, then we're gonna finish up with the homework piece, and then we'll wrap up the session. We always run out of time on these. I really apologise. But so, Stephen, your question now. Stephen asks, can you say more about defensive versus offensive pain?
Yeah, so we often think of, or the patient, I want to kill the pain, I want to get rid of it. We think of pain as the offender. So we now know that pain involves the neuroimmune system. So each nerve synapse has a cell with an immune function attached. And that cell is activated when there's evidence of danger or potential threat, whether it's, actual tissue damage or whether it's just potential threat. And I use the analogy or the metaphor of pain is a defender, meaning it's your immune system is there to try and protect you. That was really useful early on in your pain, but it's perhaps not so useful now. So that's what we want to try and, that's when I'll use the metaphor of pain as a defender, not an offender. It doesn't mean it's a good thing. It's just, let's try and downregulate your immune system. Like if you had a response to a vaccination, you're not getting a real virus, but your immune system is responding, and everyone responds differently.
Yeah, got you. That's
So
great. Thank you.
let's try and reduce that, by reducing the threat value, you can help to reduce.
Thank you. And thank you, Stephen, for that question. We've had brilliant questions today. Thank you very much to everybody in the audience. We have a question now from Catherine Harding. Do you have a particular strategy or approach to undo the entrenched belief prevalent in many patients, particularly with OA, who have been through the orthopedic system, that pain equals damage equals surgery, and that activity will worsen damage because it worsens pain? So do you have a strategy? Do you have a particular strategy or approach to counter the belief that OA patients often have, that pain equals damage equals surgery?
Yeah, and that's a hard thing to unnarrate. You're going to have to get it done eventually. You're for the scrap heap. It's OA, it's bone on bone. You're going to have to get. I'm going to have to get a knee replaced, which is very disheartening for patients and very unmotivating for them to actually, to take in an approach. Now, there's a lot of great research now with Tasha Stanton. We've got the new NEOA book, but there's plenty of evidence to demonstrate that that's actually not the case. However, when you've got a patient in front of you that's heard it, you can't help them unhear that. So I say, look, I have faith in your body. It doesn't hurt all the time. Arthritis doesn't just appear. It's a gradual progression over time, and you would make adaptations. I said, you've also developed compensation. So regardless, even if you had surgery, let's not make that decision yet. But even if you were to have surgery, you're still going to have to involve rehab to help to retrain and refocus on other areas of the body. So why don't we do that now? Learn it before you've had surgery, and that ties in with, say, prehab, and see what happens. And sometimes patients, once they buy into that as a program, they'll say, well, I don't even know if I need surgery anymore. I said, because the muscles have learned to turn on and turn off. So muscles contract and they relax. You give them basic physiology, which they can grapple with, rather than the muscle feels like it needs to hold on all the time. That muscle crosses the joint. So if that muscle feels like it has to hold on, the joint is going to get closer together, and you might get more inflammation. If those muscles learn to relax, then the joint is naturally going to move a little bit better. Motion is lotion. It will help it wear and repair rather than wear and tear.
Brilliant. Oh, I love that. So good.
All right.
Yeah, really good. And we're just going to segue back into our last part of what we said we were going to talk about, which is giving people homework after they've been face to face with you. How do you make the most of that?
Well, I think homework's a very important part. I actually learned it in during COVID. Obviously, I couldn't touch patients, which was where I sort of learned the value of touch and also how much we can do without touch. And with homework, if they say, oh, I feel really good now, or I can move, I'll say, well, think of that as a gift. And I want you to explore that space, explore that movement during the course of before our next session or over the next week, or if you're not seeing them again. And before they leave, I usually get them to write down, what were your takeaways? What's your take home message? What are your takeaways? I'm going to go wash my hands. Here's a piece of paper and a pen, or I get them to do it in their phone. Write down what your takeaways are, because I know what I tried to get across, but it's really important that I understand what you took away, and then how can we apply this? What's doable for you? So I get them to structure that before we leave, and then I'll give them a structured homework based on what they took away. So I might be like, if I breathe into my diaphragm, then I'll be able to turn my body more. So start with the breath, and this ties in very much with yoga. If they're familiar with yoga, you breathe in, then let your body follow the breath. That might be an example of their step-by-step homework. So we're breaking the movement down, and then we'll put it into, and then I can swing my tennis racket or whatever it might be. But you just keep it simple, but make it doable and meaningful.
Great.
And then hold them accountable to it,
Thank you.
without
That's
shaming.
fantastic.
Yeah.
Thank you. Now, there are a few more questions, but what I've done is I've made a note of them, and I was going to ask if Luke would maybe answer them in the clinical discussion group, because we put the recording up in there. And then, is that okay, Luke? Can you answer them, or do you want to just get through that, or do you just want to do them now?
I can answer them. I mean, do you have time for one more, or you got to run? Yeah,
it's okay. We've run over, but I'm sure that's
all right.
fine.
I'm happy to answer whatever I need to answer in the clinical.
Let's take it into the clinical discussion group, because I'm very conscious of people's time. They've probably got to get back to work and things. So, well, first and foremost, just a massive thank you, Luke, for doing one of these clinical discussions with us. It's been absolutely brilliant and different. It's always different. Whoever we have on here, whichever of the NOI teachers come on here, they're completely unique, and we've loved this session. It's been absolutely great. So just if anybody is interested in doing an explain pain course, obviously the core courses go into this kind of thing in a lot more depth. Luke will have touched on a certain level within this last half an hour, but we can only do so much in the time allowed. So there's a full schedule of global courses on the Noigroup website. I believe that your next Explain Pain course is in Ontario, Canada. Is that right, Luke? In September.
I've got one. Yeah, I will be doing. They haven't been released yet, but I will be doing something in Australia, and then US more later in the year. So,
so keep an eye out for Luke's upcoming courses. And like I say, there's a global course schedule on the website. So jump on over there if you're interested in getting on an Explain Pain course. So that is it for today. Don't forget you can watch the recording on our NOI clinical discussion YouTube channel or in the Facebook group. The links to that are in the chat, and we will also email you out a recording straight away after this. So that's it. Thanks ever so much, Luke.
Thank you very much, Joe, and thank you everyone for joining. Good night, everyone in Australia. Sleep well. Take a breath.
Thank you. Thanks for joining live, everybody.
Lovely.
Take care.
Bye. I'll be in the UK too, Joe, in June.
Oh yeah, you will. You'll be in June. Thanks a lot, guys. See you.